Assalamu alaikum ji. So this is an instructional course on strabismus made easy, and we're just going to discuss difficult strabismus cases and what the approaches are. The first session is going to be by Dr. Khwaja Khalid Shuhaib Saab, who is who did his fellowship from Australia in pediatric ophthalmology and strabismus, and he is currently working in Mughal Eye Hospital. And without further ado, I'm going to ask Khwaja Saab to come up and take the stage.
Everybody know Khwaja Saab. No problem.
We have slightly we take video of ये चेंजर Bismillahirrahmanirrahim. So I will show you a few cases of Duane retraction syndrome which I have encountered over the last few years, and so see these come under the differential diagnosis of वो आप वीडियो के ऊपर पिछली स्लाइड पे ये इसकी वीडियो चला और एक ही स्लाइड चला. So you can see there is mild limitation of abduction, and on adduction the left eye goes up. So this is upshoot of Duane with retraction of globe and narrowing of the tubular fissure. Next. So you can see again the left eye limitation of abduction, and on adduction the left eye goes down. So this is down shoot on adduction. Next slide. Video slide. So another case, you see there is, in the right eye there is limitation of abduction, and on adduction the left eye goes up. This upshoot on adduction with narrowing of palpebral fissure and retraction of globe. Next. See another case. So little bit difficult to see, but the right eye goes up on adduction. This is again upshoot. Next. So what to do for these upshoots and downshoots? So okay, slide. Next. You can see there is upshoot on adduction. Upshoot and downshoot occurs in adduction only, not in abduction. So we have differential diagnosis in case of upshoot, hypertropia, inferior-oblique overaction, and DVD. So I will deal with the rest of the video click. So DVD. So the treatment for upshoot and downshoot is recession of the lateral lectus with Y splitting. So this lateral lectus has been divided into two. This is the upper portion which has been divided, anchored, and it has also been recessed simultaneously. So this is the second portion, the inferior portion of the lateral lectus. So instead of lateral lectus like this, we have separated it in a Y, and it attached it 10 millimeter above and below the normal insertion. So this is next.
The level of insertion is the same.
If you want to do recession, then you also recess it by 6 millimeter. If you want to only do Y splitting, then that is. So you can appreciate this is pre-operative upshoot with retraction of globe and narrowing of palpebral, and this is post-op. Patient adapted, no upshoot. Next. So, पहले ये slide. So this is the.
How would you prevent narrowing?
Now, you see when the both the horizontal muscles contract,
Yeah.
they pull the eyeball behind.
Yeah.
So retraction occurs.
Because of recession, you
Yeah.
prevent
So
it.
recession and so these are the slide. So patient is having abnormal head posture. His right face turned, left head tilt. So doing patients frequently present with. So you can see on the left eye, the on erection, there is upshoot and दूसरी वाली slide. So first thing is that the normal head posture has been corrected, and secondly, you can appreciate that on the left eye, let's see, दोबारा चलाएं. The erection is all right. There is no upshoot. So this is a useful operation to correct the upshoot and downshoot. Important thing is to keep it in mind.
Sir, can we have questions in
Yes, most welcome, sir.
between?
Very
Sir,
good.
what is the possible explanation of the offshoot and possible justification of making the wide?
See, this is the eyeball medial rectus, lateral rectus. Now, the co-contraction occurs when medial rectus contracts, lateral rectus also contracts. So, it pulls that the lateral rectus is tight, fibrotic. So, it slips above or slips down the surface of the eyeball, and the eyeball goes down or up. So, basically, it is the tight muscle on the eyeball which slip over or down, causing downshoot or
This
up.
is the nice. So this is applicable both for the upshoot and for the downshoot.
Why now? Because the medial rectus is contracting and the lateral rectus is also contracting, pulling the eyeball.
I
behind.
got your point. The second point is, what is the possible explanation of recession when the abduction is already at fault?
See, many a cases these have exotropy. So there you join recession.
If there is an exotropy.
So if there is no exotropy, you may opt for only splitting. In splitting, you divide the insertion so that the
Slippage is
slipping is avoided. Slipping of the lateral rectus above or down.
So basically समझने की
10
चीज़ है कि
millimeter.
डुएंस किस वजह से? Now डुएंस is because of malformation of the 6 nuclei. उसको वो the third is doing.
Misfiring, malfiring.
Because of that malformation. So उसकी वजह से हो ये रहा है कि rather than these muscles working independently, they're pulling the eye back. तो वो जो आपकी आंख जो एडक्शन के अंदर छोटी होती है, उसकी होती है बिल्कुल आंख को पीछे ले.
कोई co-contraction of both the recta.
और उसी की वजह से वो स्लीव की इफेक्ट की वजह से ऊपर नीचे होता है. अब सर्जरी क्यों कर रहे होते हैं? देयर मल्टीपल रीजंस व्हाई वी आर डूइंग अ सर्जरी. एक तो ये अगर हेड पोस्चर उसका बहुत ज़्यादा है, उसकी वजह से
If it is abnormal, yeah.
दूसरा, अब वो नॉर्मल आंखों में भी हो सकती है, यू नो द आईज बीइंग स्ट्रेट, तब भी ये प्रॉब्लम हो सकता है. दूसरा होता है अगर ये जो हेड टर्न है वो टूट रहा है. सो इफ यू एग्जामिनिंग दीज पेशेंट्स, you have to keep on looking at this stereopsis कि वो लूज तो नहीं हो रही है. अगर वो लूज हो रही है तब भी आपको ऑपरेट करना है. And then you taking each thing independently. अगर जिस तरह फादर साहब ने बताया there is an exotropia, then you have to recess the muscle. The bottom line is कि in doing you don't resect any muscle. आपने उसको छोटा नहीं करना, ना मीडियल को ना लैटरल. आप जो भी कर रहे हैं आप सिर्फ और सिर्फ वही कर रहे हैं.
Yeah, sir, he has done fellowship in pediatric ophthalmology and still from America, USA. So he is very sound as far as pediatric ophthalmology is concerned. वो टाइम आधा घंटा फिर आपकी बात वरना मैं बोलते ही रहूँगा. Okay, so I'll be concentrating on the vertical strip.
सेम करेंगे
नहीं, फिर तो मीडियल रेक्टस की रिसेक्शन करनी चाहिए। अगर आप शूट डाउन शूट है फिर तो वाई स्प्लिटिंग करेंगे।
Only.
हाँ, और
अगर वो एक्सो में है तो फिर उसको assess करेंगे, अगर ईजो में है तो मीडी रेक्टस को assess करेंगे।
आपने जो प्राइमरी पोजीशन है ना सर,
रेक्टाइल जो है वो एक्सो में भी है, अप शूट डाउन शूट भी है, then you have to mix both by splitting and resizing. Same applies on medial rectus.
मीडियल रेक्टस के लिए हम रिसेस करते हैं, वाई स्प्लिटिंग नहीं करते। वाई स्प्लिटिंग इज फॉर
Only for the
लेटरल।
lateral. Good.
Have you tried sir this Jensen's procedure
Many times,
in
more than 10 operations.
like in if there is no
Lateral rectus palsy, we split the lateral rectus, and I will show you
Superior and inferior as well.
inferior. So we combine the lateral half of the superior rectus with the superior half of the lateral rectus, and likewise. So excellent. Maybe I will show you. Not only the primary position is improved, but also the abduction is improved. So there is improvement in the lateral rectus function.
Cosmetically acceptable.
So in all the pediatric muscle, pediatric squints, our first target is to achieve alignment in the primary position. And secondarily, we are interested in improving the range of the movement. If we can improve the abduction, it is a bonus. But the first priority,
So what is the extent of splitting of lateral rectus?
Half
Splitting.
half split. आधा split करेंगे lateral, आधा नीचे आधा ऊपर.
so in Jensen
10
procedure, we do half-half.
How length?
More length? No, about 10 to 15 millimeters. So, okay, so coming to vertical strabismus, there are hypertrophy, hypertrophy, and DVD. We are interested in a detailed history and especially examining the. So this was a patient who entered my office with this posture. He was moving about like this. Spear of deep palsy and a normal head posture. So we do ocular examination and pass 3-step test to know that which eye is hypertrophic, in which gaze it is more, and which head tilt makes it worse. Do the diplopia charting and Maddox rod to measure it. So to detect the cyclotorsion, this is X cyclotortion, and after inferior oblique weakening procedure, it has been corrected. You can also do fundus photography, blind spot mapping, and iris photography. So double mode Maddox gives a very accurate assessment. All these methods give us a measurement of the vertical squint. So I want to come to the management. See, this is hypotropia. Patient present with ptosis. Lift the eye and you can see the eye is down. And on elevation, the eye does not go up. So previously it was called double elevator palsy. Now it's called monocular elevation deficiency. And I will skip this. So we have different options. We can do, so this is left monocular elevation deficiency. And after inferior rectus recession of about 5 millimeter, you can see the inferior limbus now. So, and 1 millimeter of correction gives you 3 prism diopter correction after the vertical squints are adjusted. So there is a limit to it. More than 8 millimeter is not possible because it interferes with the inferior lid function. So another case having MED left, and you see pre-operatively eyeball is down, and post-operatively after inferior rectus recession, it's almost the same level. So this is the NAP procedure. Medial rectus and lateral rectus disinserted and attached on the side of the superior rectus. If the amount of the hypotropia is more, we go for a NAP procedure. It is Foster modification. in which at 10 to 12 millimeter, you lift this muscle up with the help of a suture and anchor it above so that its effect is achieved. So this is the superior rectus, medial rectus and lateral rectus have been attached on the sides. And this is the pre-op condition and this is the post-op condition. See, the eyeball has been lifted up, but there is slight exotropia. Another case, you can see this is
How was the inferior rectus in this?
inferior rectus. You see, when we make planning, we consider two things. Number one, on force reduction test, if there is restriction, we have to do inferior rectus recession. If there is no restriction, we can do only nap procedure. Then the amount of hypotrophy, if it is let's say, less than 10, 15, prism doctor will go for inferior rectus recession. If it is more,
There is no restriction.
yes, because it is more time stable. In nap procedure, when we disinsert the two muscles attached, we are not sure what would be the final outcome. So we will makhi marne ke liye top nahi chahani chahiye. So if the squint is less, hypotropia is less, I will go for inferior rectus resection. If it's more than 20 prism diopter, I will go for nap procedure. So there is another option. You have
If the hypotropia is more, we do lap procedure, medial and lateral, fully disinserted and attached with the superior.
superior rectus.
So वो तो नीचे को और pull करेंगे
वो
कि नहीं?
नहीं, जब वो आप superior rectus के साथ अटैच करते हैं ना, तो फिर वो एलिवेट हो जाता है.
Augment करते हैं.
हाँ, वो जो आई बॉल की पोजीशन डाउन होती है ना, वो ऊपर आए. So this is an nap procedure. If there is hypotropia with horizontal squint, you can do modified nap. I'll show you. So you can see this is hypotropia, and with nap the eyeball is lifted up.
5 minutes
Okay.
बता रहा हूँ आपको.
बिल्कुल ठीक.
आप आगे लेके जाना चाहते हैं, लेके जा सकते हैं.
नहीं, कोई मसला नहीं. ये चल दिया. तो मैं नेक्स्ट कहता जाऊंगा आप करते हैं. So this is patient having hypotropia as well as exotropia. So I have done modified nap. Next. This is pre-op. You can see the eye is not elevating and is exotropia. Next. So this is modified, in which you split the two recti, medial and lateral, attach the superior horse along the superior rectus, so that the inferior. So this is the horizontal recti. I have divided it into two, and the superior halves are attached on the side of the superior rectus. So I have hooked the superior rectus. So this is, you can see the post-op. Exotropia is corrected as well as hypotropia is corrected. So this is
नहीं एक्सोट्रोपिया कैसे करेंगे?
exotropia, horizontal muscles जो है उनकी recession resection.
अच्छा रिसेशन किया.
हाँ. So you simultaneously do, because the vertical muscle surgery will not improve the horizontal.
So there is a combination of recession and resection
Plus.
with the transposition,
With the
partial transposition.
You see, what is the advantage? The advantage is that you are manipulating only two muscles. If you want to correct the horizontal as well as the vertical, you will have to do 4 muscle surgery. And more than doing 2 muscle surgery will give rise to anterior segment ischemia.
Yeah.
So we avoid, especially in adults, especially in old age, they are more prone to have. So we want to do minimum muscle surgery. So this is Callahan procedure. मैं सिर्फ इसको बता दूँ फिर उसके बाद. So this is alternative for nap in old age, when we are more afraid of anterior segment ischemia. We split the recti like Jensen-like procedure. We do for lateral rectus, and we do inferior rectus resection as well as splitting surplice.
आपने जो फुल नैप जो करते हैं पूरा मसल, उसमें रिसेक्शन आप
उसमें सिर्फ हाइपोट्रोपिया, सो आई विल डू
एक्सोट्रोपिया आल्सो।
तो फिर मैं मॉडिफाइड डैम करूँगा। मॉडिफाइड डैम में थोड़े सा 1/3 या हाफ मसल को मैं छोड़ दूंगा और जो ऊपर वाला 2/3 है या हाफ है उसको ऊपर ले जाऊंगा और उसको रिसेक्ट कीजिए। सो आई विल करेक्ट बोथ। ओके, सो दिस इज डीवीडी एंड आई गोज अप अंडर द ये द वीडियो स्लाइड। सो so the eye goes up. Now see, when you remove the video, then there is so this is manifest on left hand. So what we were doing, ये जरा skip कर दूंगा, इसकी ट्रीटमेंट पे जाता हूँ। So पहले we were doing frost suture, sorry, Faden procedure. Faden procedure में क्या करते थे, superior rectus को 5 to 10 millimeter recess करके 10 millimeter behind इसको stitch करते थे। But the problem was that, so you can see this is the pre-op and this is the post-op. So ये था कि जब आप यहाँ पे stitch कर रहे होते थे तो superior oblique भी यहाँ पे है इसके नीचे। So you have to pull the superior oblique anteriorly and apply the suture 10 millimeter behind the incision. बड़ा मुश्किल काम था। So what we are doing now is कि 15 millimeter, 10 to 15 millimeter superior rectus की recession कर देते हैं बस। और Faden, so latest research अगर आप literature की करें तो उसमें popular method now is not Faden but superior rectus recession of 10 to 15 millimeter।
तो 10 to 15 वो इक्वेटर से पीछे उसकी तो यूटिलिटी खत्म हो जाएगी।
वो हैंग बैग होता है ना, हैंग बैग में ये होता है कि प्राइमरी पोजीशन में उसका जो लेवल ऑफ मेन प्रॉब्लम क्या है, डीवीडी में आंख ऊपर जा रही है बार बार, superior rectus इज ओवर एक्टिव, तो उसको दोबारा अपनी औकात पे लाने के लिए उसको आप रिलैक्स कर, रिसेस कर। सो आई बॉल विल, ये मैं आपको इसके दिखाऊंगा, ये पोस्ट ऑपरेटिवली
जी सर, उनका जो कैप साहब का जो पॉइंट है ना कि 10 मिलीमीटर पीछे गया, इट मींस यू आर गोइंग बिहाइंड द इक्वेटर एंड द एलिवेशन इज एट रिस्क, जो नॉर्मल एलिवेशन है दैट विल बी एट रिस्क, खत्म हो जाएगी।
सर देखिए, पहली बात मैंने जो कही है ना वो ये है कि वी आर कंसर्न्ड मोस्ट विद द पोजीशन इन द प्राइमरी केस। सबसे पहले जो हमारे ज़हन में आता है ना कि स्क्विंट का पेशेंट्स को ठीक करना है तो क्या ठीक कर, हर काम ठीक नहीं हो सकता। सो पहले आप करेंगे प्राइमरी पोजीशन में, अगर आंख सीधी है तो यू हैव अचीव्ड 99% ऑफ योर एम। आप कितना वक्त ऐसे ऊपर करके फेर रहे होते हैं, कितनी ज़्यादा एलिवेशन यूज़ करते हैं, आपकी आंख सामने देखते हुए सीधी है, शुक्र करें। तब देखे ना, सामने देखते हुए आंख है बार बार ऊपर जा रही है, उसको तो कंट्रोल कर लिया आपने, बाकी चीजें भूल गए।
बाकी जो सब्सिडरी एक्शन करने वाले जो एलिवेशन वाले मसल्स हैं वो कुछ ना कुछ वो भी तो एलिवेशन करेंगे।
वो सर है ही ओवर एक्टिव, यानी अगर नॉर्मल होता तो फिर उसकी डेफिशिएंसी हो जाती, ये तो आउट ऑफ कंट्रोल हुआ है, इसलिए उसको रिसर्च
बोटॉक्स ट्राई किया इसको,
बहुत ज्यादा करना पड़ता है। तो मतलब आप 10 to 15 मिलीमीटर की रिसेक्शन कर रहे हैं, फिर जाके ये कंट्रोल होता है डीवीडी। तो ये अंडर कवर देखें, ये मेरे ख्याल में टाइम ओके। सो आई विल स्किप डीवीडी। और सो थर्ड नर्व पॉलिसी में क्या होता है कि दो नर्व्स आपकी बच गई हैं, लैटरल रेक्टस और सुपीरियर ओब्लिक। आंख बाहर खींच रही है और नीचे जा रही है, तो जो नीचे जा रही है हाइपोट्रोपिया, उसको अवॉइड करने के लिए व्हाट वुड यू डू, दैट वन ऑफ द ऑप्शन इज यू कट द टेंडन, टेनोटमी। द अदर ऑप्शन इज वो फिर अटैच हो जाता है, so you transpose the superior oblique tendon from lateral side to medial side of superior rectus, और इसको स्कॉट प्रोसीजर कहते हैं। so this is called transposition। ये the transposition, ये आप अगर देखें तो ये मैंने superior rectus पकड़ा हुआ है, ये जो फ्लैशी सा है ये superior oblique है, इसको इधर से डिसइंसर्ट किया और इस साइड पे अटैच कर दिया, तो ये बजाय डिप्रेसर के एलिवेटर बन जाएगा। तो जो आँख बार बार नीचे चली जाती है थर्ड नर्व पाल्सी में, वो ऊपर आ जाएगी. So this is one of the procedures. अब next is inferior oblique overaction. Primary भी हो सकता है और secondary भी हो सकता है. Eye goes up in adduction. So this is inferior oblique overaction. ये देख, आँख ऊपर गई हुई है adduction में. The eye goes up in adduction. So this can be primary, secondary. In secondary, you have hypertropia. I will not go into details. So हम करते क्या है? We have a long list of operations that can be done for inferior oblique overaction. ये weakening procedures है. मैं सिर्फ ये 3 करूँगा जो ज़्यादा popular है, बाकी ज़रा कम popular है. So ये inferior oblique है. Attached on the lower side of the lateral rectus. If you disinsert it and bring down, this is called recession. So if you bring it here or here or here, this is +1 correction, +2 correction, +3 correction. So these are the sites where we can attach, and this is so normally हम moderate जो recession करते हैं वो ये है 4 millimeter behind and 2 millimeter lateral to the inferior rectus. इसकी जरा click करेंगे वो. So this is inferior oblique myectomy. 10 to 12 millimeter behind the limbus, we pass the hook and under direct visualization, we pick up the inferior oblique. और अंधेरे में टामक तो ये नहीं मारनी, उसको देख के फिर उसको pick करना. We cut 5 to 10 millimeter of the portion of the inferior oblique end. So this is myectomy, the simplest procedure. I will not go into detail. And this is pre-op, this is post-op, pre-op, this is post-op. So I'll skip all this and come to the other. So this is a patient, he was also moving like this. This is ocular torticollis, right? So you have to identify, and with superior surgery of myectomy plus inferior rectus recession, you can see this is pre-op hypertrophy and this is pre-op post-op. So if there is pre-oblique palsy, you can do pre-oblique tuck, and if there is more of torsional element, we can do Radhaito procedure, the disinserting the anterior half and inserting it close to the lateral rectus. So inferior oblique, if you disinsert and attach on the nasal side, this is called anterior nasal transposition. And if you attach it on the temporal side, this is temporal, anterior temporal transposition. So this is a long subject. I will.
Very nice and very informative.
I have taken much of the time of.
No, I don't mind, sir. I don't mind at all.
Sorry for that.
Not at all, sir. So, two things that I want to mention. आपने जो एक सवाल पूछा था about DVD. You have to understand that both eyes aren't working together. So the superior rectus is not working with the superior rectus of the other eye. Also, the reasons for DVD are either superior rectus overaction, which is not coordinating with the other one, or inferior oblique overaction. So you need to kind of do both. और जब आप इतनी ज़्यादा recession करते हैं तो उनकी primary position में कोई problem नहीं होती. वो जब ऊपर आँख जा रही है, because that is where the superior rectus works more, तब उसका action weaken हो जाता है. So I'm Ali Ayaz. I'm working as an associate professor in King Edward Medical University. I did my fellowship from Liverpool and then from Boston, and I've been here since 2014. I'll try to run through this. I don't have videos. My conflict of interest is I did a book. I obviously get some money from it, and I have a YouTube channel called Ophthalmology with MAS, which the things that I'll be discussing, you'll probably find the videos there if you want to see. So it has a playlist of strabismus, and then for residents and medical students, clinical examination videos, and it's evolving. So I'm going to show cases, and I want you to get involved also. So the first case is a 9-year-old accompanied with a mother who complains that she lifts her chin while focusing on things. She has had this problem since birth. She was basically, the mother was a nurse, and she's gone to many doctors who said, let her grow, and she'll be fine. She has a twin sister who does not have the same problem. All the doctors said, kuch nahi hai, aage chalo, aage chalo, aage chalo, and this is how she was. So she has this very obvious chin up. On examination, the Hirschberg was normal, but when she looks at the left, she has a left hypertropia. So normally, अगर left hypertropia हो और inferior oblique का issue हो तो वो right के अंदर बढ़ेगा. You know the marching orders?
Medial territory.
Yes. This seems to be the opposite.
Yeah.
So ortho here. So whenever she was being seen by doctors, Hirschberg, ortho, nothing to do. Head tilt, ऐसा बढ़ता जाएगा, ये वैसी आदत है, इसका सर सीधा करते रहो. अब वो बहुत फ्रस्ट्रेट हो रही थी because you know a twin with no head tilt और इसको हर वक्त कहना कि सर सीधा करो, सर सीधा करो, सर सीधा करो. Here was the problem. We looked at the extraocular motility. So if you see here, this eye in adduction goes further down. So if you draw a line from here to here, either it's going further down. When she looks up, so lever elevation, this eye isn't going as high as this one. What do you think this is?
Superior oblique over it.
This is the Browns. And what you have to do, what you have to do in Browns is you first need to, so when looking in and up, the eye will not go up. When in and down, the eye will be lower than the affected one. Sometimes the affected eye would be lower than primary gaze also. और वो है जब primary gaze के अंदर issue आ रहा होता है. आगे चलो. So what to do next? What will you do next? You first see whether this is something which is, you're going to confirm the diagnosis with fundus torsion. Now I love doing fundus torsion because एक होता है double maddox करना जिसके अंदर आपको subjective torsion का पता चलता है. लेकिन अगर वो पैदाइश से है तो उसने तो वैसे ही उस चीज़ को अडाप्ट कर लिया हुआ. तो आप काफ़ी दफ़ा डबल मैडॉक्स करते हो, आपको किसी किस्म की, अस्सलाम वालेकुम सर, आप डबल मैडॉक्स करते हो और आपको किसी किस्म की भी ये टॉर्शन पेशेंट नहीं बता रहा होता. एंड देन यू से अच्छा यार ये ओब्लिक्स का तो इशू है ही नहीं तो रहने दो. What I like to do is I like to look at fundus torsion. So what I do is I dilate the patient, I take a 20D, I give them a target at 20, ताकि उसके ऊपर वो देख रहे हो and then see where the macula is in relation to the optic nerve. Guyton came up with this and उससे बहुत easily पता चल जाता है कि intorsion है या extorsion and tells you कि कौन सा oblique का issue चल रहा है और या rectal का issue चल रहा है. And the second thing that you do is you determine you determine whether it is congenital or acquired. Because obviously if it's congenital, then आपका subjective torsion तो आनी नहीं. लेकिन अगर acquired है तो आपको subjective torsion आना शुरू हो जाएगा. और acquired के बहुत reasons हैं. आपका treatment plan सारा बदल जाता है based on whether it being acquired or congenital. आगे चलें. So I asked for pictures of childhood. Twin sister, no chin up, chin up. Twin sister, no chin up, chin up. So I knew that this is not something which has evolved. This is something which has been there from day one. आगे चलें. Case 2. Mother came and said this eye is lower. You see this? So what I did was, and with kids, whenever you're looking at it, they're not very cooperative, especially at this age. Show them your face. So I showed them, I was moving my face so that I could see what the eye movements are. Please remember, strabismus is not cover-uncover or Hirschberg. Strabismus is a triad. What's the visual acuity? What's the cover-uncover? What's the extraocular motility? More often than not, you will find things on extraocular motility rather than anything else. So move the head. This eye goes further down than that. Once again, Browns. What are the options? If it's acquired, you give anti-inflammatory drugs. If it's acquired, you try injection steroids in the trochlea. If it's not acquired, you go to superior oblique. अब superior oblique से लोग डरते हैं. अभी इन्होंने भी बताया कि अगर आपका superior oblique palsy है, तो या आप inferior oblique को weaken कर सकते हो या superior oblique को tight कर सकते हो. Majority लोग superior oblique को tight करने से घबराते हैं. And वो घबराते इसलिए क्योंकि जब tight करते हैं तो Browns हो जाते हैं. उसका एक simple सच है कि if the in superior oblique palsies, if the diplopia is more here, you work on the superior oblique. If it's more here, you work on the inferior oblique. And normally, this works perfectly fine. So what you do for this is you do superior oblique weakening. There are two ways of doing it. One is the controlled way and the other is the non-controlled way. So this is the superior oblique. You give a nick here and then you give a nick here. No. You're not cutting it completely. आधा nick इधर दिया, 1/3 tendon, 1/3 tendon दूसरी तरफ ऊपर की तरफ से दिया, and then you pull it. That's lengthening. That's Z myotomy. And what you do is, what I like to do it is, on the table, I look at the torsion, I also mark the limbus, and then I see कि वो torsion कितनी बेहतर हुई है. अब आप देख लें जो आपने बैठे हुए torsion देखते हैं वो बहुत फर्क होती है लेटते हुए. So you always need to mark it, and उसके बाद आप देख लेते हैं. The problem with this is, it's not controlled. कितना उसको pull करना है, कितना उसको lengthen करना है, एक problem हो जाती है. So what I like to do is use the ethibond and do a guarded tenotomy. So I put an ethibond on one side, ethibond on the other side, cut it, and then separate it. एक adjustable लगाया knot, check किया torsion कितनी है, उसकी force reduction check की, और अगर उसको मैं बढ़ाना है तो मैं बढ़ा दिया या कम कर दिया. So that's more control. I like doing that, but sometimes when I'm teaching residents, I like them to see how Z myotomy works also. आगे चलेंगे. So first post-op, you see how the chin lift is gone. She was like so, and now she's like so. And if you see here, the eye is still going down more than this one. But इधर ऊपर जाते हुए both are equal. So we've gotten what we want, and as Khwaja Sahab had said, our primary aim is to deal with what the problem is. Primary is because आप normally क्या करते हैं? If I have to look here, I will move my eyes slightly and then move my head. So I have this 15 degrees range which I need to fix anywhere. And the face chin up is gone. And I operated on her in 2014 when I came back. She comes, sees me once a year. She's perfect, mashallah. आगे चलें. Case 3. 6-year-old with outward deviation of the left eye and a lid droop since birth. The left eye does not move up or down, but while looking down, the lid droops and droop gets better. On examination, the visual acuity was 20/25 in the right eye, 20/40 in the left. So on examination, she has the left eye going out. On dextroversion, there is no adduction of the left eye. It doesn't go up. This movement is complete, and then it doesn't go down compared to this eye. ठीक? आगे चलें. Case 4, 18-year-old with sudden outward deviation of the left eye. ये 3-4 cases में तो 7 दिखा के उसके बाद I want to explain what it is. There's a past surgical history of left lateral rectus recession after this of 7 mm and left medial rectus resection of 8 mm. Post surgery, there was no effect on the deviation. The deviation at distance and near is 123 prism diopter. Big deviation, they did a recess resect, no effect whatsoever. आगे चलें. This was the guy. You can see this conch scar mark of recess resect. The eye isn't going in, the eye isn't going up, the eye isn't going as down as this one. ठीक? आगे चलें. Case 5, 60-year-old with new onset deviation of the left eye. She has diplopia in all gazes while looking at left. इन 3 cases में जो एक फर्क है वो ये है कि किस एज में ये हो रहा है. बच्चा था, कोई डिप्लोपिया की कंप्लेंट नहीं है. अर्ली एज में है, कोई डिप्लोपिया की वो नहीं है, बिकॉज इतनी प्लास्टिसिटी है कि दे ओवरकम इट, सप्रेशन आ जाती है. 18 साल की बच्ची में भी डिप्लोपिया नहीं हो रहा था, इधर डिप्लोपिया होना शुरू हो गया. शी 60-year-old, एवरीथिंग इज फिक्सेटेड एंड सेट. ये उसी तरह होता है जिस तरह हम ओल्डर एज के अंदर ग्लासेस को चेंज करते हैं. हमारा थोड़ा सा एक्सेस इधर उधर हो जाए तो पेशेंट शोर मचाना शुरू कर देते हैं, बिकॉज दे आर सो फिक्सेटेड इन व्हाट द माइंड नोज एंड इट्स नॉट एज फ्लेक्सिबल. 18 साल के अंदर डिप्लोपिया नहीं हो रहा था, 6 साल की उम्र में तो वैसे ही नहीं होगा, इसमें हो रहा है डिप्लोपिया. Once again, a big deviation. Ugly slide. The eye doesn't go in, the eye doesn't go as up, the eye doesn't go as down. आगे चलेंगे. Case 6, 25-year-old with outward deviation of left eye since birth. Once again, no complaint of diplopia. 2020, big deviation. So what do you, आगे चलें. Eye doesn't go in, eye doesn't go up, eye is not going down. आगे चलें. So all of these cases are third nerve palsies. How do you deal with them? Now, few things. One, they did a recess resect, it hasn't really helped. So is recess resect the best possible option? B, if it's not the option, then what do? You can do a lateral rectus orbital fixation, but then जो उसकी थोड़ी सी movement है, वो भी आपने lose कर दी. Correct? So what options do you have? इसी तरह रहना है सारी जिंदगी, इस आंख पे पैच लगा लो ताकि डिप्लोपिया कवर हो जाए, प्रिज्म्स दे दो, लेकिन इतने बड़े प्रिज्म्स तो दे नहीं सकते. But before we go to a surgical treatment, we need to first see कि आपके कहाँ कहाँ क्या क्या प्रॉब्लम हो रही होती है थर्ड नर्व में और उसमें आपने कैसे आगे चलना है. So if there's a nuclear problem, it could either be isolated or have neurological symptoms. So you look, whenever you see a third nerve, you start involving neurology. Fascicular problem will always produce neurological symptoms associated with the midbrain usually. आगे चलें. Subarachnoid portion बेरी एनेरिज्म की वजह से होता है, आइसोलेटेड होता है. यानी अगर आइसोलेटेड है तो इसका ये मतलब नहीं है कि आपने उसके वर्कअप नहीं करना, बिकॉज अगर एनेरिज्म है और कल को एनेरिज्म फट गया तो वो जिंदगी से भी जाएंगे. Cavernous, normally the other nerves start getting involved. Fourth nerve, fifth nerve, sixth nerve. Orbital portion के अंदर superior inferior division होती है, उसके अंदर सिर्फ isolated आ रहा होता है. So you always go for an MR scan. So I don't like CT. CT causes a lot of radiation. CT is not good at looking at soft tissue. I want a focus on the midbrain, so I want that soft tissue details. I usually say कि MR scan करना है with very thin slices so that I can see as much as possible. And we get a neurological consult. Take home message, even if there is no neurological signs that you are seeing, you still get an MR scan. If there are no neurological signs that you're seeing, you're still going to send him to a neurologist, him or her. And this is a treatment that I like doing. What we do is we split the lateral rectus, exactly just kind of why splitting में बताया था. We split it into half, but we split it all the way back. जितना पीछे आप जा सकते हो उतना पीछे जाके you bring it from underneath the superior rectus and superior oblique, ऊपर वाला उसका, और नीचे वाला we bring it down from underneath the inferior rectus and behind the inferior oblique, and we go and we attach it on the medial rectus. So we're doing a lateral rectus split transposition where आँख ये है, and we are taking the lateral rectus, splitting it all the way back and wrapping it around the eye and shifting it to the medial rectus.
How would it reach?
So एक बेस पे lateral rectus को काटा,
उसको खींच के
मीडियल लेक्टस मिड बॉडी में लगाएंगे या आगे
नहीं
लगाएंगे?
सिर्फ पूरा काटा, मैं आपको बता रहा हूँ मैं क्या किया. पूरा काटा, यहाँ से घुमाया
पीछे से
और घुमा के इंसर्शन के पास लगा के I like to do adjustable, ताकि अगर उसके बाद और मैं आपको केस दिखाता हूँ, वो adjustable को आप फिर shift कर सकते हो. And we did MR scans. There are 4 or 5 papers of ours on this. Canadian journal के अंदर, APOS के अंदर मैं उसकी आपको list दे दूँगा. The complication that has been seen in one case is out of, we've done a multi-centered, multi-continent, multi-centered thing, was choroidal effusion which settled in a week. 2 patients में आई थी, 80 patients का data देखकर. And आगे चलें. First child, the eyes are straight. There is better movement on adduction. Move कर दिया हुआ ना. There is some movement on adduction, and I've gotten that 15 degrees of movement. नहीं एक काम. आगे चलें. This case जिसकी पहले recess resect हुई थी, जब हमने किया तो इसकी esotropia हो गया. तो इसका फिर क्योंकि वो adjustable पे था, हमने उसको एडजस्ट किया, वो मसल पीछे चले गए, जब मसल पीछे चले गए तो सीधी हो गई। आगे चलें। This case, once again, she's straight in primary, some movement here, some movement here. I have that 15 degrees box that I wanted. आगे चलें। This patient, slight esotropia, I had to adjust. वही जो मैं hang back किया, adjustable किया था, उसको थोड़ा सा पीछे किया, and then she was straight. Now, case 7. 18-year-old complains of inward deviation of left eye. 2 years back, she's seeing horizontal double. The double is enough to cause her to leave her studies. The double is more in extreme cases. Referred for surgical correction for esotropia. आगे चलें. So we saw this girl, पढ़ाई छोड़ दी हुई है, कुछ नहीं कर रही, घर पे बैठी हुई है, डिप्लोपिया है. She has this massive esotropia. And when she tries to look at the left, the eye doesn't go out. Lateral rectus palsy. But when she looks at the right, the eye doesn't go out. So she has bilateral palsy. First thing is, अगर ये बचपन से है तो क्रॉस फिक्सेशन का भी डर होता है. So we need to first see कि ये pseudo bilateral palsy है या असल palsy है. So what we do is we do a patch for half an hour and then see them again, the eye movements. अगर वो पूरी हो गई है तो इसकी क्रॉस फिक्सेशन थी. अगर वो पूरी नहीं हो रही तो अब bilateral है. तो अगर bilateral है तो हमें क्या करना चाहिए? Excellent. Yes. Whenever you see bilateral palsies, think here, not here. She was sent to me for esotropia surgery with a diagnosis of lateral rectus palsy, एक आर्म का. But in patients का आप surgery always has to be the last point. You need to first work it out. So we did. आगे करें. आगे चलें. So I would want to, I've taken my notes. I would want to get MRI scan to see if there's pathology in the brain to have caused bilateral abduction deficit. I want particular focus on the ventricles and the midbrain area one time. ये मैं वो जो neuroradiologist को भेजा था. If all comes out clear, I would want to do force duction test followed by maximal bilateral medial rectus recession and bilateral superior rectus transposition. In all likelihood, I will require 2 surgeries to get the right alignment. So, MR scan वापस आया. Findings are suggestive of aggressive tumor in prepontine cistern, sella and left paracellular regions involving the cavernous sinus, most likely lymphoma. If you had operated on her, she would have lost her life. If you had not looked at the extraocular motility, she would have lost her life. So it's
How old was this problem?
it was a recent problem. 18 साल की बच्ची, very recent problem. I think 6 महीने से इधर हो चल रहा. I haven't written the time. Last case. I'm sorry, I'm just running slightly. आगे चलो. ऊपर. So ऊपर. Case 8. हाँ, नीचे आ जाओ.
6 महीने aggressive tumor हो, कुछ नहीं कर रहा था pontine area.
सिर्फ इतनी प्लास्टिसिटी होती है कि आप you can't think, it's impossible to think. मैं आपको बता रहा हूँ ये 2-3 ये टर्शरी केयर हॉस्पिटल से मुझे रेफर हुआ था, लाहौर के टर्शरी केयर हॉस्पिटल से रेफर हुआ था, और वही मैंने वापस भेजा था उसका MRI कराने, just so that it's on board. So take home messages, squint, you cannot just do a Hirschberg and say अच्छा यार तुम्हें नहीं है, वहम है, और अच्छा इसका ये कर लें. It has to be. So I do a different orthoptic clinic where I'm seeing 6 to 8 patients in a day, just so that I can get everything done. I have a problem. I have complicated cases anyway, तो उस वजह से ज़्यादा time लग जाता है. But I like to measure it in 9 positions of gaze, even if it's a straightforward squint. So. 18-year-old complains of inward deviation of both sides post-strabismus surgery. Seeing horizontal double, the double is enough that she cannot walk without stumbling. She was once again referred for management of esotropia. So now, आगे चलें. If you look at her, she has an esotropia. And everything seems fine, but when she looks here, she does not have any deficit. when she looks here, there is AB deficit.
Yeah.
So rather than me trying to say कि अच्छा यार अभी जिस तरह हम कहते हैं स्क्विंट में अभी तक चंद महीने वेट कर लो और उसके बाद हम इसको करेक्ट कर लेंगे, I knew I had to go in because I knew there was either a slippage of muscle or a lost muscle. Well, not lost muscle, but a slippage of muscle. Also, even if there's a lost muscle, आपके मसल्स के इतने सेकेंडरी और टर्शरी एक्शंस हैं कि आपको कभी कभार वो पूरी एबीडक्शन डेफिसिट नहीं मिल रही होती, थोड़ी ही सी मिल रही होती है. बट अटेंशन टू डिटेल इज वेरी इंपॉर्टेंट. आगे चलें. सो व्हेन आई लुक्ड एट इट, यू सी दिस, ये 3/4 मसल चिपका हुआ है और ये थोड़ा सा मसल सिक्योर ही नहीं है. सो दिस इज गोइंग टू कॉज सम deficit, and the muscle was found at 14 millimeter from the insertion. So it was slight, it was much further back, behind the equator, and even though it's behind the equator, आपकी कुछ movement आ रही है, थोड़ी सी missing है. And then we advanced the left muscle to manage a target of 60% diopter because जो मैंने measure किया था, ऊपर she was having a distance ET of 60% diopter, near ET of 35% diopter. Take home message, when you see these cases, forget what has been done, focus on the measurements that you get in. You operate for the measurements that you get in. आगे चलें. So we advanced it. For 60% diopter आपने about 8.5 millimeter resect करना होता है, तो I advanced it there, and I did a left inferior oblique myectomy because इसका upshoot भी था. आगे चलें. First post-op week, this is the patient. अभी भी पूरी डेविएशन आंख बाहर नहीं जा रही. So I was sorry, और अंदर भी थोड़ी सी कम जा रही है. So this is one time where you are going to get tempted कि अच्छा यार अब थोड़ा सा वापस और खींच लूँ because अब वो आंख उधर नहीं जा रही. But for such cases जो रीऑप्स हैं और स्पेशली इतनी जल्दी रीऑप्स हैं, मसल थोड़ा सा पैरालिसिस या पॉल्जी में गया होता है. So you wait it out. आगे चलें. Post-op day week 8, the eyes are straight, the movements are complete, and she is very happy. So take home message, look at the extraocular motilities, take home message, look at every case in isolation, look beyond the eyes, take home message, don't be too aggressive with the surgeries, sometimes you need to wait, and patient tells you a lot. So when patient says, मुझे ये हो रहा है और मुझे डॉक्टर ने कहा है कि इसका कुछ नहीं करना और ये तुम्हारा वहम है, please disregard it. Listen to what the patient says, and then once you have that information, you start sifting things, and then move forward.
Very nice. Very nice.
Thank you. Thank you.
Two queries.
जी sir.
Two queries. पहला तो ये है कि how much, this much of deviation of squint, 135, and how you have measured that? It's a big job.
जी sir.
It's such a big
जी sir.
difference. So if you have some videos,
जी.
do tell us. That's the one.
Sir, for the measurements of squint, hopefully we are going to have videos on that channel also. So if you just go on that channel.
135 degrees.
जी sir.
135 present out.
Present out.
Yeah,
That's
present
about 45, 45.
That's
नहीं,
about
sir, नहीं, sir,
नहीं
नहीं, sir, नहीं।
60 के करीब,
नहीं,
60.
135%
सर आपके पास प्रेजेंस दो में आ रही है, एक
अच्छा वो
दो
दोनों
में
को
और
लगा
दूसरे फ्लैट हैं. अब उसके ऊपर भी एक जो इम्पोर्टेंट चीज़ है, when you are put, let's say you have a 60% diopter here और उससे ज़्यादा है, तो आप इस आंख के ऊपर ही नहीं रखते, आप दूसरी आंख के ऊपर रखते. So we are keeping it both.
Even then 135 degrees is quite a big issue.
Absolutely.
Prism diopter.
Measurable.
Not degree, prism
I know.
diopter. That's the first question. Query. Second was regarding the third nerve pulse, where you have split the lateral rectus to the maximum,
Yes, sir.
and you have just you placed it very close to the medial rectus, and then an adjustable suture, hang back or whatever. How you have done that? I mean, how much post-operatively are they adjusting?
Sir, so the window that you have to adjust is till, for me, is about first week post-op. उसके बाद adjust नहीं होते, because वहाँ आपकी addition वगैरह आ
Don't
जाती हैं.
think first week is too much time.
No sir, I'll tell you what happens. First day, you start having additions, but they are additions which are breakable with a squint hook. So what I do is, I hold the muscle and then आप ये जब देखेंगे ना lateral rectus ये जो slip की वीडियो अगर उस पे जाके आप देखेंगे चैनल पे आपको नजर आएगा that was done 3 days after the surgery और वहाँ efficiency but if you pull it and pass a squint hook and sweep it वो टूट जाते हैं एक हफ्ते के बाद वो नहीं टूटते what my colleagues in the US are doing is कि ऐसे पेशेंट्स के अंदर वो सबकॉन्श स्टीरॉयड लगा रहे हैं ताकि उनको 10 दिन मिल जाए बट हफ्ते से आगे तो मैं वैसे ही घबराता हूँ करते हुए वो लोग 10 दिन कर लेते हैं बेस्ड ऑन दिस स्टीरॉयड इंजेक्शन बट हो जाता है सॉरी अच्छा आई एम गोइंग टू ट्राई दैट
ऐसी जेल्स हैं जो डिले करती हैं हीलिंग लेकिन वो पोर्सिन बेस पे बनी हुई है वो हमारे यहाँ होती हैं दे आर मच थिकर देन द हायर दिस आर लिथाइन सो दे यूज्ड टू यूज इट इन ट्रैप्स
राइट
तो उसको ब्लेस को मेंटेन करने के लिए 4-5 महीने वो पड़ी रहती है जाती
आई एम गोइंग टू लुक इट
वो पोर्सिन I brought it a few from America, but it had a porcine content. तो conscious मेरा था कि ये नहीं डालना.
Thank you. I'm still going to look it up. Thank you. Any other question?
When you did that third palsy surgery, I mean, the muscle is that long that you have to drag it like I mean, even if you strip.
You would be surprised. So if you cut it as far back and you're going about 18 to 20 mm back, the problem that you have is when you have not been able to pass it under the obliques. So you need to kind of, once again, if you look at the video, I'm sorry, I'm not advertising the channel.
I've seen the video, but I've always wondered how you drag or,
Yeah, so you basically isolating the muscle, so you pass a hook from the superior rectus, then you pass a hook from the superior oblique, and then you pass it underneath. You usually do not have a problem in the inferior side, but superior side, yes. And you need to kind of gently sift it forward. If you've broken the adhesions, it doesn't cause a problem. We had one slip when I was in the US, primarily because we weren't able to break the tenons and go underneath the oblique, superior oblique. Are we good?
And one more question. Your superior obliques, the plasty that you do, and have you had a problem doing that? And the post-operative picture that you are thinking you always achieve through this?
No, I don't. As I said, I don't like the superior oblique Z myotomy primarily because it's not a controlled procedure. It's just in the dark. I like the guarded stenotomy, but I have done Z myotomy. I do want my residents to do it just so that they get a hang of catching the superior oblique and doing it. So yes, I have had 2 cases where I did Z myotomy and then I had to do an inferior oblique myectomy also because of that uncontrolled growth. So I don't like that, but it's a procedure that's there, so I wanted to mention it. Thank you.
Excellent.